Welcome. My name is Ashley Starr, and I am so excited to share my DNP scholarly project with you. My project is titled Reducing Secondary Traumatic Stress in Nurses by Implementing Trauma-Informed Care Training. I would like to extend my sincere gratitude to the committee members for my project. First, I would like to discuss the background and the significance of this project. The aim of this project was to decrease secondary traumatic stress in nurses by implementing training in trauma-informed care. In order to fully understand this aim, we must first define the concepts of secondary traumatic stress and trauma-informed care. Secondary traumatic stress is the natural consequent behaviors and emotions resulting from knowledge about a traumatizing event. Trauma-informed care is a philosophy that asks, what happened to you, instead of asking, what is wrong with you? Trauma-informed care relies on 6 principles. These principles include safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. The significance of secondary traumatic stress is that while it has always been present and problematic for those in the helping professions, such as nursing, the prevalence in all fields has risen dramatically in the wake of the COVID-19 pandemic. The prevalence of secondary traumatic stress in nurses is up to 91% post-pandemic. Not only does the presence of secondary traumatic stress impact nurses' well-being, it also impacts their ability to provide safe and quality care to patients. To deepen my own understanding of the current literature on these topics, I conducted a comprehensive literature review. This also allowed me to see relevant connections between the concepts and assisted in the planning and design of the project. To find relevant articles, I used the Cumulative Index to Nursing and Allied Health Literature and the Medline Complete search engines. I used keywords such as secondary traumatic stress, trauma-informed care, and nurses. 102 articles were found relevant, and 15 articles were selected for use in this literature review. The 15 articles were grouped based upon the themes of secondary traumatic stress, trauma-informed care, and patient outcomes. While reviewing the literature on secondary traumatic stress, I focused on identifying appropriate ways to identify and quantify secondary traumatic stress, and also on methods of reducing secondary traumatic stress. I found that secondary traumatic stress occurs in all helping professions. This includes healthcare workers, social workers, therapists, teachers, and many other allied professions. I also found that there is a multitude of risk factors that can predispose somebody to developing secondary traumatic stress. These include the obvious frequent exposure to trauma or suffering, but also poor organizational culture, lack of workplace support, presence of burnout or compassion fatigue, feelings of regret about job performance. There were also some protective factors that I identified. These included compassion satisfaction, good self-awareness, and resilience. The symptoms of secondary traumatic stress include feelings of depression and anxiety, insomnia, cognitive and memory issues, preoccupation with events, and increased susceptibility to illness. In addition to these negative mental health effects, the effects of secondary traumatic stress also include a higher likelihood of medical errors. In fact, nurses with secondary traumatic stress are twice as likely to make a medication error. They also are more likely to exercise compromised clinical judgment and are involved in more unpleasant interactions. The DSM recognizes secondary traumatic stress disorder, which is the prolonged presence of the symptoms of secondary traumatic stress. This diagnosis is modeled on the intrusion, arousal, and avoidance symptoms of post-traumatic stress disorder. In reviewing the literature on trauma-informed care, I found that trauma-informed care leads to improved communication and more positive interactions, as well as a greater perception of safety for both patients and staff, increased peer support, greater job satisfaction, an overall better quality of life, and an increased ability to be vulnerable. I also identified essential concepts associated with trauma-informed care. These, of course, include the 6 principles that were discussed in a prior slide, as well as different types of trauma, the 3 E's of trauma, and the 4 R's of trauma-informed care. The 3 E's of trauma is event, experience, and effect. That means, what was the event that was traumatic? How did the person experience that event? And what is the ongoing effect in their life? The 4 R's of trauma-informed care include realize, recognize, respond, and resist re-traumatization. This calls on a trauma-informed provider to realize the widespread impact of trauma in a society, to recognize the signs and symptoms of trauma in patients, to respond by using their knowledge to promote psychologically and physically safe environments, and to take steps to reduce re-traumatization. Trauma-informed care also recognizes various types of trauma. These include acute, which is a single episode type event, such as a car accident or a violent attack. It includes complex trauma, which is repeated trauma over time. A good example of that might be child abuse or domestic violence in the home. It includes historical trauma, which is the cumulative effect on a group of people. An example of this might be the oppression of African American persons within the United States. It includes vicarious trauma, which is the secondary trauma that is relevant to this project. That is the continuous exposure to other traumatized people. It includes sanctuary trauma, which is when a place that is supposed to be of support and healing is somewhere that causes harm. This could be a person's home or their church, for example. And finally, collective trauma, which is something that is experienced by a group as a whole. A great example of this is the recent pandemic. Other examples include war, genocide, or mass violence. In reviewing the literature on patient outcomes, I identified significant links between these themes. Trauma-informed care, for example, occurs at both the individual level and the collective level by causing organizational culture change. Trauma-informed care also demands the recognition and preventative action on secondary traumatic stress. Trauma-informed care is linked to positive patient outcomes and reduced secondary traumatic stress, while secondary traumatic stress is linked to more poor outcomes. The positive effects of trauma-informed care on patient outcomes include increased patient satisfaction, increased adherence to care plans and medications, and increased staff retention. The negative outcomes associated with secondary traumatic stress include negative interactions, decreased patient safety, increased medication errors, and increased arousal and intrusion symptoms for nurses. The theoretical framework on which this project was modeled was Imogen King's theory of goal attainment. The key elements of King's theory are well aligned with common themes found in discussions about trauma. These key elements include self, perception, role, communication, interaction, transaction, growth and development, time, space, and stress. We must consider the nurse-patient dyad that is central to King's framework. This nurse-patient dyad focuses not on the traditional unidirectional relationship between a nurse and patient where there's a power differential that exists. Rather, it relies on a bidirectional relationship or a partnership between nurse and patient. This is a core theme found in trauma-informed care, where we return power to patients by the use of empowerment, voice, and choice. King's theory of goal attainment also focuses on interpersonal systems. This is relevant because nurses are the working wheel of healthcare. Trauma-informed culture addresses the social systems that are in place within healthcare. When I say that nurses are the working wheel, what I mean is that nurses are often the go-between of communication between every party involved in a patient's care. They are communicating with the patient themselves, they are communicating with the patient's family, with the patient care tech, with the physician, with the advanced practice provider, with the case manager, and with physical therapy. They're communicating with dietary staff and environmental staff. Every party that's involved in the patient's care also interacts with the nurse. Nurses are truly the working wheel that makes the healthcare system continue to go round. So if we can improve the interpersonal interactions that are happening for a nurse, then we will be addressing trauma-informed culture. Moving on to methods and design. The methodology for this project was a quantitative exploratory design. Pre-intervention and post-intervention Qualtrics surveys were used to collect secondary traumatic stress scale scores. The secondary traumatic stress scale is a self-reported measure that includes 17 symptom-related questions, which ask how often over the last 7 days have you experienced this symptom. It is scored based on a Likert scale from 0 to 4 for each question to give a total score of 0 to 68. This secondary traumatic stress scale was developed in 2004 by Brian Bride for use with social workers and has since been expanded to many other professions and has been found both valid and reliable across the board of professions as well as in many different languages. The intervention used in this project was a pre-recorded trauma-informed care training. The way that the project was delivered was that the pre-intervention surveys were sent to participants via email. 1 week following the pre-intervention surveys, the intervention or the training was also delivered to the participants' emails. 4 weeks following the delivery of the training to these emails, the post-intervention Qualtrics surveys were also delivered to the participants' emails. The setting in which this project was conducted was the Peri-Anesthesia Nursing Department of a Level 1 trauma center in the northeastern United States. The sample consisted of 28 peri-anesthesia nurses. All 28 nurses completed their pre- and post surveys as well as the intervention, and in their post survey, they attested that they had attempted to incorporate into practice what they had learned during the training. The inclusion criteria was that the participant must be between 21 and 75 years of age during all phases of the project, that they had no immediate plans of leaving the department, and that their primary role within the facility was as a peri-anesthesia nurse. This table demonstrates the descriptive statistics of nurses' secondary traumatic stress scale scores pre- and post-intervention. When looking at the table, we see that the mean pre-intervention score was 16.32 with a standard deviation of 10.51. We also see that the mean post-intervention score was 13.71 with a standard deviation of 6.68. It's interesting to note that the variability decreased post-intervention. We also see that the mean change in score was 2.61, or a decrease of 2.61, with a standard deviation of 7.81. The data analysis first required normality testing to be done on the pre- and post scores. This was because in order to run a paired samples t-test, normality criteria must have been met, and it was. A paired samples t-test was then used to examine the change in secondary traumatic stress scores of the participants. A power analysis revealed an effect size of 0.334 and a power of 0.544. This represents a medium power. The medium power was expected due to lower than desired participation. Originally, the goal was to have 41 participants or greater. Nurses' secondary traumatic stress scale scores were compared before and after the intervention. On average, nurses' secondary traumatic stress scale scores were lower after the intervention than before. A paired samples t-test indicated that this difference was statistically significant, with the p-value of 0.044. This p-value is for a one-tailed test. This project was not without limitations. The limitations of this project included a small sample size and time constraints. The target sample size for this project was 41 participants or greater. However, only 28 participants completed all steps. There were 3 participants who started the project but did not complete all steps and were therefore not able to be included in the data analysis. The other major limitation was time constraints, the biggest of which was multiple IRB revisions being required. It was originally thought that the IRB process for this project would take 8 to 12 weeks. However, the entire process, including facility and university IRB, took 11 months, causing significant delays in initiation of the project. The other contributor to time constraints was the leadership changes that took place within the peri-anesthesia department throughout the course of this. At the time site approval was sought, there was one peri-anesthesia nursing director. That person then resigned, and at the time IRB approval was sought, there was an interim director in place. And finally, at the time of project implementation, there was a third director in place for peri-anesthesia nursing. The time that it took to brief all 3 of these directors and get them on board with the project was significant. A statistically significant reduction in secondary traumatic stress scale score was observed in peri-anesthesia nurses who received trauma-informed care training. Within the 28 participants for this project, 18 had a reduction in secondary traumatic stress scale score, 3 had no change in secondary traumatic stress scale score, and 7 had an increase in their score. Of the 18 who had reductions in score, 12 had a pre-intervention score in the little to none category, and 6 participants scored mild or higher. Of the 10 who had no change or an increase, all 10 had pre-intervention scores in the little to none category. This is interesting because post-intervention, all 28 participants were categorized as little to none. There was a mean reduction in secondary traumatic stress scale score of 2.61 points. While this might seem like a small number, it becomes more significant when you look at the participants who had the most significant reduction in scores. There were 2 participants whose scores reduced by 20 points. These 2 participants are the ones who had the highest pre-intervention secondary traumatic stress scale scores. This information implies that those with the highest burden of symptoms are the ones who benefited the most from this intervention. These results do carry some implications for practice. The implication for future research is that it would be both interesting and relevant to look at the effect in other settings, such as the emergency room or the intensive care unit, where the nurses might have a higher burden of secondary traumatic stress than the ones who participated in this project. It would also be interesting and relevant to examine the effect on other healthcare workers, such as physicians, advanced practice providers, patient care techs, and others. The implication for policy is that due to the demonstrated benefit, the facility is encouraged to implement trauma-informed care training for all nurses within the organization. Finally, the implication for quality and safety is that all facilities should foster a trauma-informed organizational culture because this benefits the quality and safety provided to patients and of their staff. In conclusion, the project successfully achieved its aim, which was to decrease secondary traumatic stress in peri-anesthesia nurses by implementing trauma-informed care training. These results are being shared with facility leadership in hopes of influencing policy change. Since the project was implemented, the facility's Office of Diversity, Equity, and Inclusion has begun to offer trauma-informed care training to staff. However, this training is presently conducted on a voluntary basis. The facility is being encouraged to transition towards a model where trauma-informed care training is mandatory for all clinical staff for the benefit of the staff and the patients. Thank you so much for your engagement with this project. I'm available at the email address listed on the screen to answer any questions you may have about the project. These are the references that were used to create this presentation.